I'll get started now. So welcome everyone. Good morning, good afternoon, depends where you are in Canada. Bonjour to everyone and good to see you. And welcome to another KDE Hub webinar. My name is Alice Schmidt-Hambidge and I'm the Scientific Co-Director of the KDE Hub. And along with my colleague, Dr. Colleen McMillan, waving there. Hi, Colleen. We're opening and closing the webinar today. So we're thrilled that you can join us for our session today. So for those of you who it's your first KDE Hub webinar, a special warm welcome to you. As an introduction to who we are as the KDE Hub, the Knowledge Development and Exchange Hub. We're a government-funded, university-based organization, and we're dedicated to optimal mental health promotion and substance use prevention in Canada. So we support federally funded projects for health promotion and youth substance use prevention. And we also support a broader community and others with shared interests. So this is one of those webinars that is open to anyone interested in the particular topic. And we thank you for joining us today. So a couple of announcements. As you can see, the webinar is being recorded and we'll follow up with an event brief and slides from today's event, and they'll be posted on our Hub website. And also we'll share them in our Hub update. That's our newsletter, which you can sign up for. We have live interpretation available for those in our audience who would like to listen in French. And thanks to our interpreters today, one of our Hub team members, Eric Davenant, will also provide French support in the chat. So before we begin our agenda today, our KDE Hub is located in Southern Ontario at Renison University College, and we're affiliated with the University of Waterloo. So the land is located on the ancestral, the unceded territory of the Anishinaabe, the Haudenosaunee, and the Attawandaron peoples on the Haldimand Tract. So this land was promised to the Six Nations and includes 6 miles on either side of the Grand River that runs through Southern Ontario from mouth to source. We recognize that you as participants today live in areas across the country, and feel free to say hello in the chat and where you might reside, and also indicate which treaty you are part of. As a mental health promotion organization, we at the Hub, we strive to support mental health and well-being in a way that respects and includes Indigenous voices, perspectives, and experiences. We acknowledge the ongoing impacts of colonization and systemic inequities on Indigenous mental health, and we're dedicated to fostering an environment of inclusion, of respect, and of healing for all communities. We recognize that a lot of work remains to be done to advance decolonization and to further reconciliation. We're excited to offer you the webinar today, and it's titled Navigating Drift, Exploring Current Challenges and Opportunities in Mental Health Promotion and Upstream Prevention. So we are exploring issues related to the implementation of upstream prevention initiatives, and it's great we have such a wide variety of folks registered for the webinar today. It's super to see there's interest in upstream prevention and a topic that is near and dear to our hearts as well. We'll introduce the concept of lifestyle drift, and we'll be we'll review mechanisms of influence and related impacts. So we invite you to post any of your questions or comments in the chat. We have an interactive webinar for you today. And I'd like to introduce our presenters. So we have Dr. Tanya Halsall, pronouns she and her, and Alexis Holgram, pronouns they and them. Tanya is a scientist at the University of Ottawa, the Institute of Mental Health Research at the Royal, and an adjunct research professor in the Department of Neuroscience at Carleton University. And I'll let both of you introduce yourselves and tell us a little bit more about you. And we're thrilled that you're here with us today. So I'll pass the microphone over to you, Tanya and Alexis.
Thank you, Alice. And thank you to the KDE Hub for inviting us for this presentation, and welcome everyone. I also just want to thank our funders, A lot of our work supported by CIHR as well as SHRC, as well as thought leaders and mentors who've guided a lot of this research and ideas. In particular, Heather Orpana and the folks at the Public Health Agency of Canada, uh, Public Health New Brunswick, and our partners in the Icelandic model, and also our research partners, and of course, our lab team. So Amanda, Zach, Mahalia, Misha, and of course, Alexis. So I'll pass over to you, Alexis, so you can give your bio.
Okay, so hi everyone. Thanks for having me. I'm very excited to be here today. I'm a research assistant at the University of Ottawa's Institute of Mental Health Research at the Royal, and I've been working on upstream prevention initiatives since I was 21, including several that involve the implementation of the Icelandic prevention model. I have extensive lived experience as a young advocate starting at the age of 12. I'm really passionate about youth engagement and health equity, and I bring a unique perspective as an intersectionally marginalized young person who faces many systemic barriers. And I will move it to you now, Tanya.
Thank you, Alexis. So just briefly, I want to acknowledge that I live and work, and a lot of our youth lab research takes place on the traditional unceded territory of the Algonquin Anishinaabe peoples. And I'll pass it back to you, Alexis, to do the activity.
Okay, great. So we're going to start off with a Menti activity. So if you want to scan the QR code with your phone, or if you want to just go to menti.com and enter the code, it's also in the chat for anyone who just wants to copy and paste, which is fantastic. And then we will move on to the next slide with our question. Okay, awesome. So our question is, what interventions do you associate with the terms upstream prevention and or health promotion? And because there's a lot of you, I can't read everyone's answers, but I will definitely pick some to highlight. Oh, wow, okay. Lots appearing all at once, amazing. Okay, so housing first, okay. Um, Advocacy, policy, education, seeing the IPM come up a couple times in here. Planet Youth, yes. Policy change, systems level change, yes. That is very much upstream for sure. School attendance, education, housing, mental wellness. Okay, interesting. Addressing social determinants of health, definitely upstream. Early intervention. Okay, so we're seeing a lot of different answers here. And that's really great because this highlights that folks can have different definitions for upstream prevention or health promotion. Okay, I'm seeing like harm reduction as well, poverty reduction, ACEs, okay, yep, adverse childhood experiences. Okay, yeah, all sorts of different definitions there and examples. Okay, I will throw it back over to you, Tanya.
Thank you, Alexis. Um, yeah, so, and thank you everyone for participating in that activity. We wanted to lead off with that because we've used it a couple of times in conference presentations, and we're using it also in our research. And it's always nice to sort of get a sense of folks' perspective and see the diversity in the room. I think many people are working in mental health promotion, upstream prevention. And so often we'll see even more of a spread in terms of perspectives, depending on where we're having this discussion and activity. But I think the takeaway is that there's a lot of diversity in prevention, and I'll go into some conceptual frameworks and models and sort of go into definitions a little bit more and highlight that this is, I think, reflective of the literature as well as the system. So just to highlight what we'll be talking about today, we're exploring some concepts, theories, and interventions related to upstream prevention and health promotion, largely using the language of prevention. We'll also relate this to the concept of lifestyle drift and talk a little bit about the research that we're doing and some of our work trying to address lifestyle drift. So I wanted to start off just talking a little bit about where this work came from. So my background, my academic background is in human kinetics and psychology. And most of my previous research has been focused on the positive youth development approach, which is based on this model, the bioecological model, but largely applied in terms of community-based programming, often in after-school sports and with targeted populations. And as I did this work over the years, I became more and more interested in how we can create healthy contexts outside of programming. So thinking about the school, family, and community context as well. And more recently, since I've been working with the Icelandic prevention model, using frameworks that place a stronger focus on social determinants of health, structural determinants of health, and the mechanisms of influence through policy. So these definitions of prevention, I think, relate to these things. And what I wanted to do really is just explore kind of a sampling of different frameworks. So this definition of prevention comes from Health Canada, and it's a more simplified version where we have primary, secondary, and tertiary prevention. The primary level focuses on reducing factors that lead to health problems. So largely those kinds of efforts that are designed to create healthy contexts, to change the environment. Secondary prevention within this definition is more focused on early detection and intervention to prevent the development of health problems or specific issues. And tertiary prevention relates more to treatment and populations that have now moved into more illness rather than prevention. This definition is similar now to this framework that comes from the Association of Faculties of Medicine of Canada. So looking at the second line or the second row, it's essentially the same, except that they've divided primary into primary and primordial. So rather than just looking at how do you change contexts, it's divided more into social determinants and risk and protective factors. So looking more at broader policy versus potentially changing local living conditions. This definition comes from the National Collaborating Center for the Determinants of Health. And rather than using the terms primary, secondary, tertiary, we have upstream, midstream, and downstream. And these definitions certainly align quite well with what we've just discussed, although sort of bring in different concepts. So the first category, aligning with those social and structural determinants of health, examining how to change the cause of the causes of health and health inequities, and referring largely to provincial, territorial, as well as national and international policy frameworks. Midstream, again, is still about addressing root causes, but it is more focused on examining exposure to risk and promoting health behaviors, and conceptualize this work as happening more at the local level. Finally, downstream, again, we are looking more at treatment. So strategies are about changing the effects of the causes, and this focus is now more on the individual health and social services. I wanted to bring this framework in only because I use it a lot with the Icelandic model, in that the Icelandic model is based on the second to bottom level, that changing the context to make individuals default decisions healthy. So this framework is a little bit different. I mean, often you see pyramids when you look at population level impact versus individual. And Frieden has organized this in terms of, you have increasing population level impact as you go down the pyramid. His is a little bit different order in that counseling and education is at the very top of the pyramid. And he does this because he identifies it as relating to the highest level of individual effort needed. So where the participants or the individual target population of focus takes on a lot of the responsibility in creating health gains. And he moves the healthcare and clinical piece to the second level. And this is also different in that rather than talking about detection of risk, he describes long-lasting protective interventions and offers examples of immunization or antibiotics, preventive dental care. And he doesn't use the word prevention very often, but essentially you can see the alignments between this model and the other definitions. So finally, this one comes from the World Health Organization and comes from a report examining mental health promotion. This one is quite different from the others in that all three of these levels fall under the umbrella of their definition of primary prevention. So where those earlier conceptual models would place, I would say, primary prevention at the universal prevention within this definition. This one also includes selective prevention, where they're looking at targeted programming to at-risk individuals, and indicated prevention, where again, it is targeted programming and including individuals who are now showing signs or symptoms of illness, so moving into the treatment category. So this definition of primary prevention is quite different from the ones that I just reviewed earlier, in that primary prevention actually spans through most of the levels or several of the levels of the others. So this just contrasts the different definitions. I put Health Canada and the Association of Medical Centers here in the second row together, so they're kind of a combined one. But what I want to highlight is, in the activity we saw that prevention is defined quite differently, depending probably on where you work, what you're exposed to, what you've learned. And this makes sense because we are seeing that the literature and conceptual models have quite a bit of variation. So no one is wrong, but we are using the same language to describe very different things in many cases, which I think can be very problematic when trying to ensure that there are population level interventions in place. So for example, if we look at the integrated youth services model, which for folks who are not familiar, it's a collaborative approach that's designed to support partnership among organizations, both within mental health services as well as other social services, so that young people can be served in a more comprehensive way that tailors services to their needs. And so these models are largely focused on the mental health system. They're different based on what community they're implemented in, but for the most part, they are very much focused on selective and indicated prevention. So treatment as well as programming for high-risk individuals. But because primary prevention within this definition includes that as well, if you take a community, for example, that's implementing integrated youth services, someone who's prioritizing funding may look at that and say, oh, well, we've got primary prevention happening in that community. We don't need to invest in anything else because we're covered. But they may be using these definitions as their frame. And so it's very important, I think, going forward that sorry, I for some reason cannot see my arrow. Let's see if I can advance this minty slide. That I think that there's work needed to support stronger conceptual communication about upstream prevention, what those levels are, and what interventions are related to those levels. So I think this relates to, and certainly the case example of integrated youth services overlaps with lifestyle drift. And I'll offer a definition. So this one's from Popey, and it's a little bit of a mouthful. It's the tendency for policy to start off recognizing the need for action on upstream social determinants of health inequalities, only to drift downstream to focus largely on individual lifestyle factors. So essentially, lifestyle drift is this mechanism that essentially limits the impacts of upstream prevention initiatives because they are very often drawn downstream to intervention approaches that are not designed to impact population level outcomes. So this definition also includes kind of a secondary component. Coupled with this is a move away from action to address the social gradient, so to create health equities, towards activities targeted at the most disadvantaged. So we started using this term largely through our work with Public Health New Brunswick in 2022. And Zach from our lab actually created this conceptual model based on a lit review that we did to support the evaluation framework. And so it essentially highlights those factors that are involved in lifestyle drift that come from the political system, industry, as well as science, and what is perpetuating these problems broadly. So based on this work, we were then able to conduct a scoping review. So this publication, which is still under review, is co-first authored with Heather Opana, who actually had the idea to do the scoping review to build on our work. And this gave us an opportunity to really look at this concept within the literature and identify both what is being experienced in terms of upstream prevention, but also what work is being done to mitigate lifestyle drift. And we came up with three major findings. The two relate to how lifestyle drift is defined in the literature. So lifestyle drift definitions nearly always talk about influencing lifestyle behaviors through education, hence the term lifestyle drift. But we found through our review that they're often talking about some other nuanced types of issues. And so I'll expand on that in the next slides. In addition, the definition may not fully capture the range of contexts. So as you saw from the Popey definition, lifestyle drift relates to when policies on social determinants are drawn downstream. But in our work with the Icelandic model, we've actually seen a lot of parallels with initiatives that are designed to create healthy living conditions within communities. And finally, we identified there's a need for more research to examine how to mitigate lifestyle drift, which is a pretty common recommendation. So in terms of the definition, traditionally, it is defined at this first level, drift to education, drift to awareness campaigns. It's important to be active. It's important to eat, enough of the healthy food groups. These educational campaigns that are meant to support healthy behaviors. That's well conceptualized in the literature. Drift to targeted programming and drift to clinical interventions is not as often included in formal definitions. And I'll go into these three different mechanisms. So drift to education relates essentially to trying to change health behaviors that are somewhat complex and behaviors that people don't change just because they know they're bad for them or good for them. And so in particular, this is not talking about like quality education where, you have access to school, which creates job opportunities and like many other financial sort of independent sorts of trajectories through education. And it also doesn't relate to education within the workforce, implementation science, capacity building types of education. It's education to the individual to change their behavior. And I might give a case example, but I'll see how our time goes and maybe offer it later. But these are not limited to physical activity and nutrition. It's smoking and many other limiting your child's screen time behaviors that are not necessarily easy to do just because you know they're important. One issue with this is that initiatives that rely solely on education, don't smoke because it's bad for you, whatever the messaging is, if it is only messaging, then there is the possibility of increasing health inequities for a couple of reasons. So, say, for example, you're talking about nutrition or physical activity. Not everyone has the same privilege and opportunities to be able to afford healthy foods, have the free time to participate in physical activity, have access to those spaces where these activities can be done. And so often those people with on the higher end of the social gradient are able to implement strategies independently, which can create inequities. But in addition to this, many of these behaviors are often related to stress and our coping behaviors. And so again, you would see more people at the bottom end of the social gradient potentially not benefiting from an educational campaign. This is just a quote from Rose and Marmot that highlights that, health behaviors are based on social norms. And so it's important to change the environment. So personal lifestyles, socially conditioned. Individuals are unlikely to eat very differently from the rest of their families and social circle. It makes little sense to expect individuals to behave differently than their peers. It's more appropriate to seek a general change in behavioral norms and in the circumstances which facilitate their adoption. So multi-level strategies that are meant to create a change in the context. So drifted targeted programming, which is less commonly cited within the lifestyle drift definitions, although it is within that Popé definition that I offered. So this somewhat overlaps a bit with the educational one, as there are programs that rely heavily on education, some kind of skills training, sort of a isolated type of approach where learning and change is expected based on some kind of training or education of the target population. But there are additional problems in that often these programs can't scale to address population issues. And so it's not to say that these are not important programs. They are very important programs. Many of them are essential and tailored to those populations that they serve. And I'm not advocating for fewer of these programs. My concern is that often people rationalize that these programs can be used to create population level impacts. And they're not successful at that for several reasons. The educational component, it is not easy to scale them. And sometimes the reason it's not easy to scale them is because of stigma issues. So for example, with the Icelandic model, we see often youth programs that are very functional, effective programs, but as they are designed and marketed, other young people wouldn't participate in them because there's a stigma often related to poverty or whatever issues. There's many different angles of stigma, but since it can't bring in greater population, there isn't an opportunity to change social norms and population level behaviors. They need, I think, to be refined so that they can be used in a universal way. So rather than a breakfast program, you have a universal lunch program at school where no one has a problem participating in the second one, but those using the breakfast program may feel stigmatized. Another piece is the scaling. So this example is taken from the physical activity literature, and this is a great article. It was really impactful for me to read when I was more involved in human kinetics. But essentially, it's highlighting interventional research that comes from behavior change theories like the trans theoretical model, social cognitive theory, theory of planned behavior, where the interventions are easy to test. You can create a control group and do an RCT, but very often effect sizes are moderate at best. So there aren't big changes that are created by the interventions. It is hard to recruit people to these programs. And then when they do participate in the program, very often it's hard to maintain changes. So just given all of these aspects of these very intensive programs, so like say motivational interviewing, it's not feasible to scale this to a population either. And finally, drift to clinical interventions. And this somewhat overlaps again with the drift to targeted programming, in that a lot of the science that this is based on comes from biomedical science, which is essentially, it aligns with like a reductionist approaches and applies linear causal logic, which works, I think, very, very well when you're looking for, the cure for cancer, or maybe how effective is this medication. But when you add in, an individual's disposition, that's not always a rational type of decision making, as well as the complexity of other peers and community norms and complexities around other factors that influence it, they become less and less effective and relevant. And so I think in many ways, this approach has much more power than, the qualitative and mixed methods approaches that I come from, that are maybe better for applying to look at like complexities within community and many different factors and emergent issues. In addition, there's also kind of a crisis factor to this, in that often if someone has moved through a health issue or condition towards the downstream level, then it is much more time sensitive to serve them, and the consequences of not serving them are much more dire. And so it becomes harder to justify why you would invest time and energy further upstream when the needs of the people who are further downstream aren't being met. So just another quote quickly. A shift in thinking is required away from simple linear causal models to consideration of the ways in which processes and outcomes at all points within a system drive change. Instead of asking whether an intervention works to fix a problem, researchers should aim to identify if and how it contributes to reshaping a system in favorable ways. So instead of always trying to isolate one variable to figure out, is this finally the variable? Have we found it? Recognizing that these variables are all interacting and that they need to be taken account across the system. So in our research, again, those were the three aspects of drift, with two of them not being accounted for very well in formal definitions. There is also this aspect where most of the literature does talk about policy on social determinants, but through our work with the Icelandic model, we have certainly seen quite often instances where these similar dynamics are occurring, and challenges in addressing population level needs within community. So one piece, for example, that we're starting to identify through our research is that folks, for the most part, really do already know that social determinants are extremely important, and that risk and protective factors are also influencing these health issues. So that piece of awareness appears to be pretty strong. So when we ask people, what do you perceive causes substance use issues in your community? People talk about peer norms. They talk about adverse childhood experiences. They talk about poverty. They talk about industry advertising. But then when we start to look at what interventions exist, very often we see testimonials in schools, which is largely education focused, or folks talk about harm reduction strategies, which have now moved past the midstream into like dealing with folks who have symptoms or illness. And then we also see a lot of discussion of taking existing programs that are targeted and investing in those programs without sort of restructuring and revisualizing how they're implemented. So I just wanted to bring in a couple of frameworks that highlight interventions related to different levels within the stream. So this one comes from the Chief Public Health Officer. It was the report from 2021 focused on stigma. It doesn't have a ton of interventions, but it does have this, social and structural determinants, living conditions, risk behaviors, disease and illness, and mortality levels. And then it does highlight interventions that relate to those different levels. This one comes from Frieden. So I apologize, these are not easy to read, I think, on the slide, but maybe if you are able to look at them enlarged on your screen afterwards. So he has communicable disease, non-communicable disease, and I can't even read myself that last one. But he's got things in here about like policy on smoking, urban planning, those kinds of pieces that fit well with changing the context. And I think part of the awareness raising, and the Public Health Agency is doing work related to the Icelandic model, as well as lots of other folks, is sort of identifying and inventorying those interventions that are evidence-based that can have an impact, because often we're crossing sectors. Some urban planning efforts probably are going to help with substance use prevention, but maybe that they were originally intended for promoting physical activity or some other piece, but they're all interconnected. So I'm going to hand off to Alexis, because we've done some work in youth engagement that also has identified that lifestyle drift can create problems in this context as well. So I'll hand off to you, Alexis.
Okay, great. Thank you, Tanya. So this is the youth engagement approach that we used for the Planet Youth Lanark County project. And so you can see that we have the level of youth advisor, which really relied on youth adult partnerships. That was the foundation there. And I was part of the Lanark County Asset Mapping Working Group, which is the second part you can see there. And that was adult initiated and shared decision making. And then we also had another layer where we had Lanark County youth consultations. So those youth were consulted and informed, but weren't necessarily part of larger decision making. So I began my involvement in this project as a research assistant in the asset mapping project in 2022. And we also found that there were a few challenges that were identified in youth engagement within upstream prevention through this project. And the first one was around difficulty engaging younger youth in the higher level decision making. So we've had many debates about some of this, which is totally fine, but we found overall that there needs to be youth with higher capacity, experience, and also interest in the leadership roles that they take on in these projects. And that's not to say that youth can't receive training or other assistance to increase their capacity and take on some of those roles, because that was also part of what was offered as well. Like me and the other research assistants went through a little bit of training, and not quite a book club, but a bit of a lit review club where we learned a lot about the IPM and upstream prevention, some of us for the first time. And since we can't necessarily involve younger youth in the higher level decision making in this circumstance, it really highlights the importance of including broader consultations with really diverse young people who have key lived experience around health equity issues. The second challenge that we really identified was difficulty integrating youth-led initiatives. So we're talking about youth-initiated and youth-directed initiatives there. And youth experience and specifically lived experiences are very, very important at leadership tables. However, we found that youth-led projects were often disconnected from larger strategies. And because of that, and they were sort of often sub-projects that were smaller. And so because of that, okay. Because of that, they often weren't as impactful as the work done within the youth adult partnerships at the higher levels there. And so next slide, please. Okay, fantastic. So this is a any day now to be published paper that we go more into this work and more details on the model if folks would like to check it out when it is published. Next slide. Okay, so Planet Youth Achieve is a youth advisory council for Planet Youth Lanark County. They meet monthly and they continue to accomplish a lot of really, really fantastic work. I've met with them, they're amazing. And as we can see here, they've done a lot of things like they've developed a terms of reference, they've hosted 2 youth summits supported by the Students Commission. They've advised coalitions on safe spaces, and they've also worked on developing the lifestyle drift game and facilitation around that. So we're going to do something similar to that on the next slide that is really based on that. So next slide. Okay, great. So we have another Menti interactive activity for you. And we're looking actually to see again sort of the range of perspectives we have in the room with us today. And so we're looking for you to rank the following interventions from upstream, which you would put as first, to downstream, which is seventh. And again, these are from all throughout the range of the stream. So we're really just curious to see from their perspectives where folks would rank these. So
I'm sorry to interject. We deleted 2 of them, so there are 5 now, just to make it a little simpler.
Okay, yeah, no worries.
Keeps you on your toes.
Yep, totally, no worries. That's great. Okay. Okay, this is like pretty great, people. I am impressed. This is pretty awesome. So I'll give folks a couple more seconds to vote, and then we'll kind of have a bit more of a discussion on this. Okay. It seems like we have a pretty good consensus here. Like it seems like the spread is pretty consistent. So folks are saying that the national child care benefit is the most upstream. And yes, that is indeed correct in terms of the model that we're talking about. Second, we have a provincial ban on smoking in enclosed spaces, and that was also correct in the way that we ordered it. We then have cigarette package warnings, which yes, as well. That goes towards health and risk behaviors, that sort of thing. So we're really getting midstream there. And then fourth and fifth, it was really close there between recovery programs and naloxone kits. And both are more downstream, where naloxone kits would be more towards harm reduction. And then recovery programs, you would really find at that like quite downstream when you've started to see already that manifestation of disease and injury, and someone is already using substances and therefore is in need of more immediate individual based services there at the end of the stream. They've already fallen in. And so I will pass it back to you, Tanya, to keep going and wrap this up for us.
Thank you, Alexis. Yeah, and just to provide a bit of context, so it was actually at the First Against the Current event that I think Amanda had the idea of like creating a game out of matching interventions to their level of prevention or to their level in the stream. And when we brought it to Planet Youth Achieve, I think it resonated with them. And this is sort of building on Students Commission and sort of how we did the asset mapping, where there's like collaborative learning and experiential learning. And so it makes it much more interactive to, immerse yourself in learning about the social determinants of health and the nuances of community-based policy development or, upstream prevention approaches with population-level impacts. So Planet Youth Achieve is sort of, I think, evolving this into their work and, typically it's implemented in like more of a facilitation, but this is our mentee big group, large group version. Do we have time for this? I have just a couple more slides. Maybe we can come back to it. So in terms of our work, essentially, what we've been doing is first exploring lifestyle drift and sort of observing what folks are dealing with in their work and in their communities. And what we're trying to do is apply implementation science frameworks, which they mostly come from the biomedical system and have had sort of a linear translation type of focus. And in these, it looks quite different in these collaborative environments where you don't have people who are on your payroll who are going to do exactly what you tell them. So, we're really trying to adapt this to like these grassroots, community-driven initiatives. And so part of what we're doing is first measuring knowledge and understanding. So some of what we did with these mentees is like what we're also doing in our research. Measuring contextual risks. So I'm going to share a recruitment poster of what we're trying to do. This is quite similar to implementation science research, where you look at facilitators and barriers and what is going to create challenges in implementing a new initiative. And so we're calling this one of our lifestyle drift tools. In addition to this, we're also trying to create tools that measure fidelity to evidence-based interventions. So these are more tailored to specific models, and we're creating one for the Icelandic model. We'd like to use this to first create opportunities to incentivize fidelity, which is hoped that this reduces lifestyle drift in these contexts, but also to generate more evidence in terms of looking at fidelity and how it relates to health outcomes. And so this is just, one piece, I think, of this super complex puzzle that hopefully helps to move the bar in terms of population health and health equity. And relatedly, we wanted to let you guys know about some recruitment that we're doing right now. So we're actually implementing a few different components of a study that looks at both the Icelandic prevention model, but also examines interventions across the continuum. So this recruitment poster is from a needs assessment that we're doing, which originally was conceptualized to examine lessons learned from integrated youth services, which has very successfully scaled across Canada and applies collaborative approaches. And so that is meaningful learning that can be implemented to upstream types of approaches that also requires many of those same partners at the table. in implementing it, we are also recognizing that maybe it doesn't have to always be someone in integrated use services or the Icelandic model, because they work with many other partners. And so really we want to examine opportunities and challenges supporting coordination across the continuum. So between upstream prevention, that midstream, as well as downstream, and how can folks work better together, and what are they dealing with in their contexts that we can learn from to try and support. So that's one recruitment that we're doing. The second one is for our fidelity measurement. Sorry, not fidelity measurement. It's the context measurement of lifestyle drift. So similar to tools that are used with the consolidated framework for implementation research, we would like to create a tool that can measure the context and whether that context is conducive to lifestyle drift or not. So looking at, funding environment, looking at community partnerships, looking at disciplines and understanding of prevention, examining the influence of industry and challenges related to policy and election cycles and funding terms and reporting requirements. So all of those pieces we're hoping to explore in terms of public health actors. So folks who are working more in the upstream, more in the primary prevention types of approaches and what they're experiencing in the community. So if you are interested in those and would like to share your insights, we are very curious to speak with you. And so I think Amanda Balfe, who's our project manager, or myself, whoever you'd like to get a hold of. Yeah, that is really it. I have lots more that I can talk about, but I wanted to make sure we had enough time for questions and discussion. I don't know, Katie, did you want to jump in here, or how did you guys want to transition into the discussion questions?
Yeah, so maybe we can invite anyone who has a question. You can either raise your hand, and Tanya, you should be able to see those folks pop to the top of the list, or you can put your question in the chat, and I'll keep an eye on the chat. And Tanya and Alexis, I can let you know if I can convey questions from the chat over to you. So I'll give folks a minute to think about it, and yeah, feel free to turn your mic on and ask and put up your hand, or put your question in the chat. See, we have one hand raised already. Diane, you can go ahead. Oh, your mic is off.
There we go. Okay, hi. It's Diane Oikle. I'm actually with the National Collaborating Center for Determinants of Health, and I can't even tell you how excited I am right now. The timing for me, the timing for this work couldn't be better. So I'll probably be in touch, Tanya and Alexis, afterwards. So you might know about, so that the glossary definitions that you had up, that's part of the work that I was involved with in developing the glossary, but we're also revising our document called Let's Talk Moving Upstream, which is, I think, 11 years old right now. And I'm literally, yesterday was working on the revisions for that document, right? And how the concepts have evolved and how they apply to public health. And, now that our concepts around social and structural determinants are so much different than they were 10 years ago. So just the timing for this is really perfect. I do have a question, but I have one more comment too about why I'm excited, because I used to work for the Leeds-Grenville-Lanark District Health Unit. And so Lanark County was my county. Some of my colleagues are online, Rebecca Shams and I work together. So I'm just like, my heart is like so warm right now. I'm like going back. So I've got lots I want to talk to you about, but my question is around how these concepts of downstream, midstream, upstream map onto not just social, but those structural determinants, because more and more we have been talking about structural level determinants, right? Values and worldviews and, big stuff like racism and colonization and stigma discrimination, heterosexism, all the big, powerful forces, right? And so as I've been playing with these concepts, how to, yeah, how to bring all that in when it's also big too. So it's not a greatly formed question, but have you had those discussions, or what have you heard about those sort of bigger societal forces beyond the social determinants?
Oh, thank you very much for that question, Diane. And we are so grateful for all the great work that you guys are doing, and we use the resources that are available from you folks as well as the other centers as often as we can. And small world, it's nice to know that everybody's interconnected. So, I mean, I agree with you. I feel like it's already been 2 months, I feel like, since January, that I think a lot of us are asking these questions like, how did we get here? And how do we fix it, especially with what's going on in the States and things that seem to be moving backwards, not like only backwards of 20, 30, 40, like progress made over many, many years. And I think it is really complex. And I think part of what I've been learning with the Icelandic model and also like from my research partners, like this is all inspired by my work with partners and can't acknowledge how much they help in this work. But I think it is helping people to see themselves as a part of these initiatives because it is going to be a very comprehensive effort. I mean, our most recent work is focused on commercial determinants of health, which seems so far away when your work is youth programming or, mental health therapy, and those trainings are completely different and paradigms are completely different. But I think that we will not make great impacts without each other, and so we need to find ways to learn to work better together. And yeah, I mean, how do we turn around these forces of like capitalism and profit and help folks recognize that they're working against health and human health and planetary health, and that we're all needed in this and a part of this. So it's a great question. I maybe didn't give an answer.
Can I add to that as well, if that's all right? I was also going to add that for us as a lab, we are the youth lab and specifically focusing on upstream prevention and health. And at the very center of who we are as a lab, we're a small team, but we have these conversations often. It's something that we're encouraged to show up as ourselves with our lived experience. I am quite frequently told that my own lived experience and also like background in advocacy, youth engagement, all of that is an asset to this work. And so that's something that is, I think, maybe fundamentally different about the way that we work together in our little team, at least starting there, is that we bring a lot of those intersectional lenses and already thinking of like different barriers and systemic challenges before we even get started with the work, really. And yeah, hopefully that helps.
Yeah, it does. Thank you. I'll be in touch though.
Awesome. And we have a question in the chat as well, from Paige. Paige says, first of all, awesome presentation. I agree personally. Question, do you have any thoughts on how frontline staff at public health units could start affecting change, acknowledging that we're often working against politics and structures, so feeding back into our previous question, that are directly responsible for funding public health? That's the question. I can read it again if needed.
Thank you for that question. And yeah, I mean, I have certainly heard about this challenge and frustrations about this challenge from public health units. And not coming from that context, but working with folks like Rebecca and Jessica Austin within the Icelandic model, and learning from their work and how they're contributing to these issues. I know I won't be able to give a very um, formalized response to this, but I think it again falls in line with working in collaboration. So if you're not able to advocate, maybe pulling somebody like myself in who has a bit more independence in what I can say to folks. And, those communications around, this is a new problem that has come up. How can we address this? I do think that collaboration is a really, really key part, which is why that youth engagement model really fundamentally integrates lived experience as a partner within the higher decision-making pieces, because that lens should be at the table with the other lenses. I'm sorry, I'm just looking at your question to see if I answered it. Just how feeling that. Yeah, I think that's it, is really pulling in those partners that can be a voice for you. And I think already, Jessica's already doing this work, I think, in identifying where there are opportunities for leverage and how to move them forward. I don't know if she's on this call, but I learned a lot from her in this work.
And there's just a follow-up comment there too that I think speaks to part of the issue as well, from Alyssa saying so many truly upstream interventions require higher levels of government. I think that's what pushes our work further downstream more than anything, right? So that working in a local public health unit, but some of these upstream things really are all of society, require, maybe a federal initiative or something national. So there's, yeah, just adding context to that initial question. There are currently no other questions in the chat, so feel free to raise your hands or put your question in the chat. And that includes folks from the Hub team, if anyone on our team has questions as well.
I can't find my hand, but I have a question if I could. You did mention in part of the presentation that as an indicator, we should be thinking about how does this contribute to reshaping the system in favorable ways. And, every time we make an annual plan in public health, we're required to have indicators and demonstrate that it's working. And things that have indicators are often short term and downstream. So I'm wondering, and if we don't have indicators, we can't do the work. So is there are there indicators specifically developed to answer these questions, like a framework or something that someone could share? Like how does this contribute to reshaping the system in favorable ways is a big question. And unless I could demonstrate that the work I'm doing can have an impact using some kind of indicator, I can't always carry on with the work. So I'm just wondering more about indicators and how that plays out.
That's a great question. Thank you. And again, I'm not familiar with public health work plans, but I have heard about this in some of our research. So in 2022, we collected like an earlier version of this lifestyle drift barriers facilitators tool that we're trying to create. And one of our findings, which we still are almost at submission with that paper, was this challenge around people being pushed to add in indicators that set them up for failure, because it's not possible to demonstrate change in the amount of time that the expectations are for the funding. And they also like sort of draw the attention downstream to more individualized types of interventions. And so they kind of are creating challenges on multiple angles. And with the Icelandic model, we're having those same problems. Like, I think people will be wanting to know if it's made a difference, possibly long before it's really feasible. And so looking for those intermediary measurements. And like, certainly I think changes in risk and protective factors should show up before changes in substance use behaviors and major health outcomes and, well-being. And so, I think that gives a little bit of lead time. And certainly the lead author, I think was, I'm completely forgetting right now, but the Icelandic model study that was done during COVID in Kentucky, and essentially, it was only 2 surveys. The, the change in time was 2 years. And the leisure card pilot that they implemented showed major uptake in after school activities, which I think is a huge success in a short turnaround. So I think there are opportunities like within these Icelandic model projects. In addition to that, what we're trying to do with these implementation measures is, capture changes in practice, capture changes in knowledge and training and in fidelity to the evidence. And I don't know if that would be a fit for your indicators, but those are earlier measures of success as well, hopefully.
Any other questions or comments? We can problem solve together how we can measure, how we can create and measure upstream indicators. It's an ongoing conversation, I know, here at the Hub and across all of the projects we serve as well. Colleen has a hand up.
Thanks. Thanks, Katie. And thanks, Tanya and Alexis. I have closing remarks, but just listening to you, I had a question and just wondering if I could get your thoughts on it. It's about lifestyle drift, and when you speak to people and you look at the literature, there's at least I've noticed such a tension between downstream and upstream. And that tension between the two, it's almost a binary thinking. You have to be one or you have to be the other, right? These two kinds of camps. I see, Trevor, you're nodding with me, so maybe you can expand. And I think there's a whole section there, and you did address it in the model, where people actually do both, right? There are people who see that it's not linear, like you said, it's circular, one feeds the other. But I'm just wondering, like how do we address that tension so it's not so competitive, it's more collaborative? Because I feel like unless we address that tension, we're kind of doing parallel versus kind of like a real intersectional. So I don't know if you want to add on to that, Trevor. I just see that you're nodding there as well, or that kind of captures your thinking as well.
Yeah, I have the exact same question and the same experience. Talk about lifestyle drift. It happened 15 minutes after we got the funding to begin Iceland prevention model work, right? We're always being drifted off into this other no man's land. And it's very frustrating, that tension. I'm very interested in the answer to this question. Very, very. And we've had so many conversations about it already. And yeah, the intersection of these, I don't even want to call them two initiatives, but the intersection of these is so important. And it just seems like an impossibility to drag interventionists into prevention understanding. Yeah, anyway, I'm not sure if I added to your question or put more confusion into it, but
it was perfect. Thank you. And maybe it's because, like, I don't know, like Trevor, I think you like I do both. I do the clinical work, but I'm also at the hub. And when you sit in that space, you see that tension and you wonder, like, what is perpetuating that? Or like what is feeding that? Because it is a barrier and it doesn't have to be.
Yeah, I certainly don't have I don't as the solution at all, but hopefully some of this work will help. But yeah, I've certainly learned a lot from folks that I've worked with, both in the Icelandic model, but also in integrated youth services. And it a bit, I think, comes back to my earlier question in recognizing strengths and opportunities for complementarities instead of overlaps, because there's always potential for overlaps, I think. And partnerships are hard. Like, my son gave he gave an argument the other day on group work and why it doesn't work. And I was like, it's fair. It's not always easy, especially in high school. And, and it happens to adults as well. And so, I think that, you know, David Sompi's work and identifying where folks can help each other is very similar to what I learned in my mentors in integrated youth services as well, and in some cases. And I do think that, like I was on a call this morning getting ready for a Lanark County event, and it's really people seeing themselves in the initiatives and creatively contributing to solutions. So not that this came from Lanark County, but it was actually from a conversation with your coordinator, Trevor, in Reykjavik last week, talking about the training, like gender diversity training, which is I think, a really important a thing that we need to do in Lanark County that the young people have identified to support safe spaces. And the youth centers in Lanark County have done extremely good work in that area and potentially could partner with the school boards to do some training to create safer spaces at school. So I think there's a place for everyone, just like what Alexis was saying, like in terms of lived experience, in terms of job skills, and there will be many, many frustrations along the way until we find a place for everybody, I feel like.
Looks like maybe we have, I don't see any questions in the chat. Maybe one last call for questions before we pass it over to Colleen, or additional comments. This can be a conversation. It doesn't have to be didactic. Like we're good. All right, maybe I will pass it on to I don't think, Tanya, you were done with your slides, correct? So maybe if Dan can reshare the slides for just the hub's last closing slide, that'd be fantastic. And then I'll pass it over to you, Colleen.
Yeah, thanks, Dan, for posting that, and thank you, Katie. And I just have a few concluding remarks, and of course, if anyone else has any other questions, I'm sure Katie is happy to keep her eye on the chat there. But yeah, this concludes our time together, and like really what a fabulous presentation and discussion on the concepts of lifestyle drift and upstream prevention and health promotion, and some of the challenges that you mentioned, including language and diversity in definitions, but also some opportunities. And I'm really glad the questions really took us there at the end. What are some of these opportunities for collaboration? I feel like after today that we can all proceed toward collaboration in an informed way, in a collaborative way. So thank you for the array of models and really breaking them down to us this afternoon. Like I, for one, really appreciated the clarity and the accessibility of language that you both use to explain these really multi-dimensional and complex concepts. Also, we had a great turnout today, and that just speaks to this is a really high interest topic. And so we are really appreciative. I know my colleagues at the Hub, as well as everyone who attended today, of your knowledge and expertise of this topic, Tanya and Alexis. So a huge thank you to you both. And of course, we're all eagerly awaiting to see those articles that are soon to be published. Just another note of appreciation on behalf of my colleagues. We want to thank each and every one of you who made time in your busy schedule to join us this afternoon. So as you know, if you've attended an event at the Hub, we value your feedback as much as we value your presence in our events. So as you depart, there's just a very brief, it's 3 questions that will pop into your screen as you're leaving the Zoom link. And if you could kindly answer those questions, we would be really appreciative. I think that if you've attended a webinar, you know that we at the Hub, we're always looking for different ways, better ways of meeting your needs. And so we really do look forward to that feedback. Dan did share a slide with you, something that we want you to know that we at the Hub, we are busy putting together our virtual annual symposium in the first week of June. And you can find more information on that in a variety of ways in our newsletter. Katie, thank you. Katie, you're always one step ahead. Posted our link for LinkedIn where there'll be information posted. You can check our website for emerging details about the annual symposium. Or as always, you can just reach out to any member of the team. We're more than happy to share those details with you. So we are at the end. We're going to give you that precious gift of time. So as we say goodbye, I'm looking out my window. It's an absolutely beautiful day here that promises spring in Waterloo. And I hope wherever you are, you too are enjoying some really sunny weather. And safe travels back to Calgary, Alexis. I hope there's good weather awaiting for you when you arrive. So thank you again, and we will see you the next time we reconvene. Bye for now.